Good morning, everyone. Good morning, everybody. I hope you've had your breakfast and coffee. Welcome to the Colorado Politics Healthcare Breakfast. And it's a beautiful, gorgeous Colorado morning. I'm glad that you are all able to make it today. My name is Luigi Del Puerto. I'm the editor of Colorado Politics and the Denver Gazette. Okay, quick show of hands. How many of you subscribe to Colorado Politics? Oh, that's awesome. And how many of you subscribe to the Denver Gazette? Not as awesome, but getting there. Okay. All right. Um, so for those who are not subscribers yet of Colorado Politics or the Denver Gazette, you and I are going to have a serious conversation right after this breakfast. And to those who are already subscribers, you may have noticed that we produced 31 election stories on Tuesday night. That's right, 31 election stories on Tuesday night. It was the most comprehensive coverage of election results in the state of Colorado. And that is one reason why I am so thankful for today's event and our sponsors, PhRMA and the Colorado Bioscience Association, for making this happen. It is your support that allows us to sustain the kind of operations that you're seeing. A lot of people would describe us as an objective, fair, accountability newspaper, or as I'd like to call ourselves, an equal harassment newspaper. We have a big subject this morning, a very important subject. I get reminded of it every day. My wife is a nurse, and she tells me that her industry, your industry, saves lives every day, and I'm a paid hack. I want to introduce our first speaker this morning, Dana Malik. Dana is leading PhRMA's efforts in Colorado, Utah, Wyoming, and Kansas. Dana?
Good morning, everybody. Thank you so much for being here. I will be very quick because I am certainly not the main event here. I'm not really that interesting. But I do want to say, just as a way to open this discussion, as you all know in this room, there is nothing black and white about healthcare policy and healthcare issues. It is complicated, and it's not something that we can come to conclusions on or find good solutions for in a 2-minute conversation in the back of a hallway. So thank you so much to all of you for being here, finding time to come and learn about this issue that we're going to be discussing. And I also want to thank so many of you in the room who I know are stakeholders to this issue. And we've been working together in the Capitol for many years, and sometimes we are on the same side of an issue, and sometimes we're not. But we always find time to have dialogue, to hear each other, to listen to understand instead of listen to respond. And I thank you so much for being here in that spirit. So to that end, I want to introduce my colleague, Amy Goodman, who is the vice president. I have her card right here because it's just a very fancy. She's the vice president and counsel for policy and advocacy for the Colorado Bioscience Association. And I just want to welcome her to the stage. Thank you for being such a great partner. Come on up.
Thank you, Dana, and good morning, and thank you so much to everyone for joining us this morning. On behalf of the Colorado Bioscience Association, we're excited to co-host this discussion with PhRMA and Colorado Politics today. As Dana said, I'm Amy Goodman, VP and Counsel for Policy and Advocacy for CBSA. CBSA fosters collaboration and opportunity in Colorado's life sciences ecosystem, advocating for a supportive, business-friendly climate for life sciences innovation. From concept to commercialization, CBSA's members create health innovations that improve lives worldwide. By focusing on capital and growth, education and networking, workforce cultivation, and policy and advocacy, CBSA strengthens its members, the ecosystem as a whole, and patient access to innovative therapies and technologies. We're proud of the growing and thriving life sciences ecosystem in Colorado, and we remain committed to our goal of becoming a top 5 life sciences hub in the country. The Colorado bioscience sector employs more than 38,000 Colorado residents in high-paying, purpose-driven jobs with an average salary of more than $120,000 a year. This translates to more than $4.4 billion in annual payroll in Colorado. These health innovators work every day to make meaningful impact on patient lives. But Colorado can and should do more to protect the bioscience and healthcare ecosystems and the patients they serve. We are here this morning to talk about some of the hidden costs of healthcare here in Colorado. Importantly, the federal 340B drug pricing program will be a hot topic this coming session, and it's important to have the facts. As you'll hear from our panelists, due to the massive growth of this well-intentioned program, it's now the second largest drug program behind Medicare, and there are serious questions about whether it's actually benefiting the patients it was intended to help. Plus, while some may claim there is no cost to taxpayers, employers, or the state of Colorado, recent studies point to hidden costs and some program abuses. We appreciate you getting up early to join us today and hope you'll learn something new. I'd now like to introduce our moderator, Stephanie Wiswall.
Good morning. I'm Stephanie Wiswall. I am Senior Vice President in the Healthcare Practice at Rational 360, which is a nonpartisan public affairs firm headquartered in Washington, but with people throughout the US like myself. So to kick us off in this 340B conversation, I just want to do a really quick informal poll of the audience here. I would love for you to clap your hands if you are already quite familiar with 340B. Okay. And now I would like you to clap your hands if you think that 340B might be a droid from Star Wars. Yeah, one, two, okay. This is an incredibly important health policy topic, and I will say our promise to you for giving us an hour of your time today is that you will leave here learning something new about the 340B prescription drug program, and in particular, its impact on patients, providers, employers, and taxpayers right here in Colorado. And that is because we are very lucky to have a panel of some real esteemed experts in this particular space. And so it is my pleasure to introduce them to you. First, we have Dr. Bill Smith, who is Senior Fellow in Life Sciences at the Pioneer Institute, which is a Boston-based think tank that has done some very important research on this particular topic, the 340B program. Dr. Smith is distinguished, has a very distinguished background both in private and public sector, including senior positions for House leadership on Capitol Hill, the White House, and the governor's office in Massachusetts. And although he was far too modest to put it in his bio in your packet, was recently called to testify as an expert before the House Energy and Commerce Subcommittee on this very topic, 340B. So we're very excited to have you with us, Bill. Next, we have Courtney Christian, who is Deputy Vice President of Policy and Research at PhRMA, the Pharmaceutical Research and Manufacturers of America, driving a pioneering plan to invest in communities of color. And most relevant to our conversation is looking at state policy through the lens of advancing health equity. Her credentials in this area are robust, including serving as a Director of Policy and Advocacy for the Black Women's Health Imperative. And she has, of course, won many, many awards, the most applicable being the Corporate Achievement and Image Award by the National Black Caucus of State Legislators for her work to advance health equity policy. And the health equity lens is incredibly important when we start to talk about the 340B program. And then finally, joining us by the miracles of modern technology, we will have Dr. John Campbell, who is Chief Science Officer at NPC, the National Pharmaceutical Council, which sponsors and conducts research into health policy issues related to biopharmaceutical innovation and impact on patients. John, of course, in his role leads that agenda. And in his very copious spare time has published over 250 manuscripts and abstracts and serves as adjunct faculty at Tufts University School of Medicine. So very excited to have you here with us, John. Thank you. So without further ado, to kick us off, we are going to have each of our panelists talk about the 340B program from their unique perspective, given their research and background. And I will ask Dr. Bill Smith to kick us off to explain to us a little bit more about what 340B is and what the issue is here.
Thank you. You're about to have a pretty dry policy discussion for an hour, so I thought I'd lead off with a joke. It's not related to the subject matter, and the only person it might offend is me because it's an Irish joke. So there's an Irish bar on fire, and the firefighters get there and they rush in, and there's an elderly gentleman sitting there sipping a Jameson whiskey, and there's fire blazing all around him. So they grab him up and pull him outside, and they sit him down on the fire truck, and they say, sir, do you see how the fire started? He said, no, it was on fire when I went in. Okay, so now we'll get to the policy. So 340B, what is it? Where did it come from? In the 1970s and 80s, there were certain safety net hospitals that treated a lot of the uninsured. Medicaid was not a very large program in those days. And so a lot of uninsured came in the door, and the hospitals would have to eat the cost of their care. But it was a voluntary program on the behalf of pharmaceutical companies. They extended these deep discounts to certain hospitals, what they know were struggling financially. Then under the category of no good deed goes unpunished, in 1990, Congress passed a reconciliation bill where they required the Medicaid program to get the best price of any drug anywhere in the country. So if a drug manufacturer gave United Healthcare the lowest price of $20 for a drug, that $20 had to be given to every state Medicaid program. The problem with that for the 340B program or for these drug discounts to the safety net hospitals is it risked them going away, right? The hospitals were worried, oh, these pharma companies aren't going to give these deep prices to all 50 states. So the hospitals went to the Congress, and in 1992, they passed the 340B statute. And the statute requires that hospitals give these discounts to certain hospitals that treat a lot of low-income patients. And generally, the threshold for becoming a 340B hospital is if you get 11.75% of your patient mix as Medicaid patients, you're eligible for the discounts, and you can apply to become a 340B institution. So during the first 5 or 10 years, this program worked out quite well. The safety net hospitals got a little more revenue. Oh, sorry. Yeah, that's the first slide. I'm not on the second one. But if you want to understand, how this program works and how revenue is generated, you've got to understand how in the top left on this slide, hospitals can arbitrage the discounts. And what does that mean? That means it's a Wall Street term. You buy low and you sell high, and that's how you make money. And under the 340B program, they could purchase some drugs, cancer drugs in particular, which are quite expensive these days. The average list price for a cancer drug is $200,000. So if a 340B hospital can buy that drug for $25,000 and they can get an insured patient to come in the door, they can then bill that insurance company or Medicare for $200,000, and they can pocket $175,000 profit on one prescription. And that's really what's driving this program, is the ability of hospitals to arbitrage the discounts. And what's happened is hospitals have gone out into wealthy neighborhoods and have purchased physician practices, particularly physician practices that prescribe high-cost drugs like rheumatologists or oncologists. And they've bought them up so that they can arbitrage more of the discounts. For-profit PBMs and pharmacies have rushed to this program because there's so much cash in it, and the reimbursements for pharmacies are extraordinarily higher than they would be for a regular commercial health plan. So you've had a lot of for-profit pharmacy chains and PBMs get into the program. And the program's had explosive growth. There are 10,000 entities that now are eligible to get 340B discounts when there were only about 500 in the 1990s. And part of this is the expansion of Medicaid, because as I said, you qualify when you get 11% of your patients as Medicaid, 11.75. So as they expanded Medicaid, more and more hospitals became eligible. But it's also the case, there's anecdotal cases of hospitals hiring consultants and getting the consultants to bring Medicaid patients in so they could reach that threshold and become eligible for the discounts. And so because this is such a high profit area, and as was mentioned earlier, it's now the second largest federal drug program in the country. It's exploded in growth because of this ability to arbitrage the discounts. And let me say something about hospitals, because the implication might be that I'm critical of hospitals, and that's really not the case. I have a very balanced view of hospitals. I know of hospitals in Massachusetts that do the Lord's work as far as treating uninsured and low-income patients. And they have a high percentage of Medicaid patients. The reimbursements are terrible for those Medicaid patients, so they struggle financially and they depend on 340B. On the other hand, there are also hospitals that are extremely wealthy, may be affiliated with the university. They're endowed. They have generous donors, and they also leverage the 340B program. And in the bottom right bullet, the thing that's most concerning to me about the 340B program, as it's experienced this explosive growth in revenue, average charity care of 340B hospitals has declined. And that's not my assertion. That's not my research. There are numerous academic articles that demonstrate that. And you actually can go on our website, thepioneerinstitute.org, and you can look at charity care trends for hospitals by state and by individual hospitals, if you like. So let me just close with a quick slide about Colorado. Oh, sorry. Yeah. Thank you. Because so many pharmacies have rushed in, the numbers here are a little small, but the University of Colorado Hospital, for example, contracts with 148 pharmacies to give out 340B drugs. The National Jewish Medical Center and Research Center contracts with 142 contract pharmacies. And what's curious is a lot of these pharmacies are not even in Colorado. There are 272 pharmacies in Colorado, but there are 10 in Florida that serve Colorado hospitals, 8 in California, 1 in Hawaii. I'm not sure why a program that's supposed to be helping low-income uninsured people have a vast number of pharmacies located outside of the state, and particularly in sunny areas. I don't understand that. But it's a sign that this program is so very profitable that everybody wants to get a part of it. Everybody wants to be part of it. And with that, I'm happy to take questions at the appropriate time.
Thank you so much, Phil. Now we are going to be turning to Dr. John Campbell, who's going to talk to us a little bit about the impact of 340B on the overall healthcare ecosystem.
Hi, everyone. Can you hear me all right in the room?
We can.
Okay, there's a little echo, and I think it's gone now. So I'm going to go ahead and share my screen. Can folks see that all right?
We can.
Okay, great. Well, Stephanie, thank you so much. And Dr. Smith, that was a great intro to the presentation I'm about to give. I'm John Campbell, the Chief Science Officer here at National Pharmaceutical Council, and it's a pleasure to be with you all. Something that wasn't in my bio that I should have put in is I was a faculty member at the University of Colorado at the Anschutz Medical Campus for 11 years, and that's in large part where I was logging all those papers and abstracts. So doing work in academics is sort of part and parcel to my background. And I wish I could be with you all this morning to have breakfast and enjoy the views from, it sounds like, the 38th floor up high in the Denver landscape. So I'm sorry to not be with you. I'm coming from the NPC headquarters here in Washington, D.C. And I really enjoy this topic. It's a line of research that NPC cares deeply about, and would like to share a little bit about that research that has already come out and some work that's in progress as well. So I want to Also mention my NPC collaborators, James Motika, Kimberly Westrich, and John O'Brien, our president and CEO. For those not familiar with NPC, I just wanted to give a slide here, and I will share this at the end too. NPC has been conducting policy relevant research and communicating it with impact since 1953, and so we're over a 70-year-old organization. I joined NPC in 2023 in the summer as the chief science officer, and it's been a pleasure to work with colleagues here to really bring research and to drive impact in this golden age of biopharmaceutical innovation. The work that we do is to study the role and value of innovative medicines to achieve better patient health. And I'm pleased to work with a number of other researchers here at NPC, and we conduct that work internally as well as with external partners. So for those interested to receive more about NPC and our research, as well as even for those curious about health policy kinds of topics on a weekly kind of basis, feel free to scan the QR code there at the bottom, and I'll share this slide at the end of my presentation as well. I'd like to start with a quote that blends nicely with Dr. Smith's presentation, and he used the word arbitrage. Here, the key word is diversion, but there's a similar kind of tone and concern with those kinds of words. So the quote here is, "The balance of access and innovation can be furthered if the funds expended by payers accrue to pharmaceutical innovators with a minimum amount of diversion by intermediate entities." So again, as we're in this great age of innovation for biopharmaceuticals, the hope in how we continue that innovation for the next generation of patients really lies in being able to compensate for that innovation and bring those resources that are dedicated to that to bear for the innovators. And the challenge here, as described by recent work published in New England Journal of Medicine, is that in 340B hospitals, over half of the dollars that are paid for medicines administered by 340B hospitals are actually retained by the hospital or practice. So that's that arbitrage, or in this word, diversion. So you can see that the $64 and change actually being retained by the hospital or practice for 340B hospitals. That's really concerning, and that wouldn't go alongside the quote that that suggests that, you know, really we get that balance of access and innovation by paying for things and making sure those payments go to the innovators. Non-340B hospitals are about a 50-50 split. So again, pretty concerning upcharges and markups on medicines outside of the 340B program. But that gives you a sense of how that 340B program impacts medicines compared to non-340B hospitals. So still a large amount of money going to non-340B hospitals for medicines, and yet clearly not as much as those in 340B hospitals. And finally, independent physicians, to give you a better sense of where money is going. Most of that money is heading back to manufacturers and others in the supply chain, which would be more consistent with the above quote. So that sets up the motivation for some of NPC's work. I'll give you one more slide as background here. Work published by others in the field suggests that the 340B program increases hospital revenues and profits. We've already heard that from Dr. Smith. These profits are likely related to consolidation in the hospital marketplace, and that consolidation is also driven by certain decisions to pull more and more care under the umbrella of these large hospitals like the University of Colorado and others. Since 2018, the 340B drug sales have grown by more than 3 times that of non-340B sales. And again, this nearly exponential growth in the 340B program is what's really quite concerning. As Bill was already saying, back in the 1990s, this was a pretty small program and seemed to be serving those that it was intended, and has really grown out of proportion. Finally, a previous analysis found that a very small fraction of branded prescription drugs filled at the contract pharmacies share the 340B discounts with patients. So one of the stakeholders really important to our discussion today is patients, and we'll hear more from Courtney about that topic, I would imagine. In terms of NPC's research in 340B, we have I have 2 slides on work that has been published demonstrating the cost to employers at the national level. The rest of these questions are really active lines of research that I can't present the findings of today, but that we will be rolling out in the weeks and months ahead. So in addition to employer-related stakeholders, we're concerned that patients may be not positively impacted by 340B in certain ways. And we're also concerned that some of the driving factors of 340B revenue growth are more around the quantity of prescriptions that are being filled in 340B entities rather than any other driving factors, and those need to be better studied with evidence. So I would like to just share briefly the work that we collaborated with IQVIA on, and that is in the employer space at the national level. We conducted work that sort of asked the question of, in a world today versus a world without the 340B program, what might be the impacts on employer-related costs? And again, as Bill was describing, that buy low and sell high means that payers are paying a high amount, oftentimes an unrebated amount for medicines to these 340B entities. And those concerns then are that employers are not receiving the rebates from those payments on those medicines to 340B entities. And instead, all of that profit is going to 340B hospitals. So those rebates aren't being shared back with employers. And because of that, employer costs have actually risen by this research to the tune of around $5 billion at the national level over 1 year. So that's a concerning amount, and it's an amount, again, asking the question where 340B was recently versus if 340B did not exist. And of course, that work requires a counterfactual, and so there's modeling and assumptions involved in the work. But even if those assumptions may be slightly off, this is a large amount of money, and it pushes back on the myth of a no-cost 340B program. There are impacts, in this case, to employers. The second component of this research also talked about impacts beyond the loss of rebates, and talked about, for certain self-insured employers, relationships that 340B hospitals might entertain with self-insured employers in terms of a revenue sharing agreement. And this research found that in certain circumstances, that revenue sharing agreement, even though it seems appealing to employers, may actually increase the cost to employers and to other stakeholders in the supply chain. So there are concerns there that not only the loss rebates are involved, but also in some cases there are shifts in site of care and more care being administered at 340B hospital under these revenue sharing agreements, and that could lead to higher costs that could have been served outside of the hospital setting, leading to higher costs for employers and other stakeholders. As I mentioned in the question slide, work that is actively ongoing includes estimating, not at the federal level, but at the state level, including in Colorado, the impacts to employers, including governments, for the 340B program. And so the work that's actively involved currently will have estimates for the cost to states related to 340B and including government employers. Other work that's ongoing includes the impacts of 340B on insurance premiums. There's concerns that premiums are going up due to the growth in 340B. And so there's ongoing research that NPC is involved with that relates the growth of 340B to study how that might impact changes in commercial and Affordable Care Act related insurance premiums. And finally, the determinants of 340B markup. We have active research that has concerning features around the markups of 340B and that they're actually concentrated in more affluent areas compared to others. Finally, some future lines of NPC research will focus on patient impacts and concerning features that patients aren't receiving discounts from 340B entities, as well as the revenue growth drivers of 340B. And the concern there is that it's more on the quantity side that's driving 340B growth rather than anything to do with unit price increases. So with that, I will look forward to the discussion, and again, feel free to subscribe to our weekly newsletter.
Thank you so much, John. I mean, I think we've heard 340B said as the more you peel back the onion, the more you cry, but it's important that you continue to peel back the onion there. Okay, and now we're going to turn it to Courtney to talk to us a little bit about the broader implications of 340B, particularly with regard to health equity.
Thanks so much. Hello? Hello, hello. Flip this way. Can you all hear me? Okay, great. Good morning, everyone. How are you? Okay, I'm from the South, so that's a good, one more time. Good morning, everybody. Thank you so much. Okay, so I used to work on Capitol Hill, so I enjoy a good policy discussion and into the weeds on the research, but I know all of you all really care most about impact to your neighbors here in Colorado. And so I'm so happy to be here with you all today to kind of talk about an issue that's close to my heart in terms of health equity and patient access to medicines and to quality health care. I'm here representing PhRMA with a couple of my colleagues here who flew in also from DC. And you all might know that we represent many of the world's leading biopharmaceutical companies and that we are really committed to helping patients live longer, healthier, and more productive lives. And as such, we're also committed to building a better healthcare system from our particular niche within the larger healthcare ecosystem. And so as such, we believe in the fact that every person from any racial and ethnic background should have equitable access to treatment. And we know the literature shows that health inequities, such as those driving disparities in medicine access and adherence, so staying adherent to your medicine regimen, they're often rooted in community level factors, where we live, where we work, where we play, where we pray. They're rooted in lack of adequate healthcare, insurance and coverage and access to providers. And then they're also rooted in systemic racism and discrimination, bias in the healthcare system that people have to navigate their way through in order to access care. So from our perspective at PhRMA, health equity depends upon removing those social and health system barriers to medicine access across the continuum of care. So research and development is central to what our biopharmaceutical companies do. You may not know, but it takes on average 10 to 15 years to even bring a medicine to market at a cost of $12 billion. And so that it's very important, and becomes very important, that all of the medicines that our member companies produce have efficacy for every patient so that they're able to access them when they need them at the time that they need them for the care that they need. And we begin the cycle with research and development medicines to market. Access to a provider and screenings. Is a patient able to receive a diagnosis to be treated? Are they able to receive the right prescription at the right time? Are they able to then fill that prescription? Can they access it and remain adherent so that they can improve their health outcomes? And then how are we measuring their outcomes? How are we inform? Okay, I'm just gonna take this off. How are we using that data to inform use and future innovation? And so all of that just cycles back into that cycle of research and development. So there are very high stakes here when we think about health equity and underserved populations that are often treated later for many diseases like cancer and asthma, then timely access to provider recommended medicines becomes really central to solving those issues. So achieving health equity really involves involvement from all stakeholders across the healthcare ecosystem to address social determinants of health, to access to primary care, and to medicines. And you can see here that right now the cost of health inequities is $320 billion annually, and it is projected to rise to $1 billion by 2040 if we don't get a handle on health inequity. So why does that matter to the 340B program? You can see from this slide that illustrates that 340B leaves patients in underserved communities behind. From left to right, you can see that the top performing 340B DSH hospitals collected nearly $10 in total profit for every $1 they invested in charity care. So that's the effect of that arbitrage and diversion that you just heard about. 340B DSH hospitals collected more than 2 times more in 340B margin than they spend on charity care in the middle. And then 340B DSH hospitals were below the average charity care rate for all hospitals. You heard from both of our previous speakers that the majority of 340B entities are not in vulnerable communities as they're supposed to be, as the program was originally meant to serve. And so this is antithetical, right, to the mission of the 340B program. And you can see here that just a small share of these 340B hospitals, their child sites and their contract pharmacies are located in medically underserved areas. And so what is a medically underserved area here? You can see communities in the United States with too few primary care providers. They can have a high infant mortality rate, high rates of poverty, and or a high elderly population as defined by HRSA. And you can see here there are 38% of DSH hospitals in medically underserved areas, 29 child DSH sites, and then 26% contract pharmacies. So the 340B program is not improving access to care, and again, in the communities that it's meant to serve. And you can see here of the contract pharmacies in a different zip code or in Hawaii, as Bill said, from their parent DSH hospital, that 60% are in areas with at least 10% median higher income, and 40% were in less diverse areas compared to their parent hospital. So you see these negative numbers mean that they're not in the lowest income neighborhoods. They are proliferating more in the highest income areas, which is drawing funds away from the poorer communities that need this care. And they're not in predominantly Black neighborhoods where they may have been needed and where the 340B hospitals often are providing charity care. So this is an example for the commercial market, but you can see here, if we share the manufacturer rebates that Bill and John both talked about that manufacturers provide, nearly 60% discount in 340B discounted medicines. Those rebates are not being shared to the patient at point of sale. And so if we were able to share, for instance, in this example, if we're able to share those rebates, we could reduce total health care costs by $8 billion over 10 years. We could reduce patient spending. We could cut mortality and death rates. And finally, I just wanted to share a slide showing you how much advancing health equity nationally on the left would save if we empowered people with chronic conditions to achieve better health outcomes, to remain adherent to their medicines. It would save the United States healthcare system $3.8 billion. But here in Colorado, it would save you all $62 billion if you empowered your patients to manage their chronic disease. That's $43 billion in medical costs that would be saved, $19 billion in less absenteeism at work over the next 10 years. And so I think it's critically important, as you can see here, that we do all we can to address the abuses of the 340B program to ensure that patients have access in the ways that they're meant to have access to these medicines, and that this spread, this arbitrage, this diversion gets diverted to the patient in the right way so that the patient can better receive better care at these hospitals and receive lower costs on their medicines. So with that, I'll turn it back to you, Stephanie.
Thank you so much, Courtney. Underserved patients really are at the heart of why I think everyone is here today. So we really appreciate that. But onto our panel conversation. And so I think I will start with you, Bill, if you don't mind. You talked about the growth of the program, and I'm wondering if you can set that growth in a bit of context for us, because this is obviously a program that's 30 plus years old. We've seen many economic changes over that time, inflation. What do you have to say about that?
Well, the growth is staggering. I mean, it grew 23% last year. Last year, there were 124 billion in sales in the 340B program at list prices. At discounted prices, there were 66 billion in sales. And just to give you context, the entire 50-state Medicaid program purchases about $40 billion in drugs each year. So it's a third bigger now than Medicaid. And in my view, it's going to overtake Medicare as the largest drug program within a year or two. And the growth is staggering. But however, let me put it in context. The concerning thing is not the growth, because if you're given discounts to hospitals that really need it or to patients, what's problematic about growth? It's not problematic. What's problematic is that we've seen average charity care declines. Less free care is being given, less uncompensated care is being given to low-income populations, and there's every incentive for hospitals to move into wealthier neighborhoods where you have fully insured or well-insured patients so they can arbitrage those discounts.
Courtney, I mean, you've shared that PhRMA's position is that 340B is not helping patients. Obviously, hospitals say otherwise. Where does that discrepancy stem from, and what information is available so we can really know?
No, I don't know that it's so much of a discrepancy as it is a question about the fact that the program is being abused. Whether you call it arbitrage, whether you call it diversion, patients are not getting the care that they need, and its program is moving farther away from the intent, the spirit of the letter of the law as established in 1992. And so I think that, for all of you all in the room, to the extent that you are able to access the research that Bill is doing, access the research that's happening at MPC, with the ASAP 340B coalition that's moving a lot of work on this. Like, everybody in the room needs to understand what the program is, what it was meant to do. Why are we seeing what we're seeing in terms of how this program is being implemented across hospitals and contract pharmacies? And then what does that really actually mean to patients every day, your neighbors every day, when they're going to the pharmacy trying to access care, trying to access their medicines, or they're going to the hospital trying to access care? What does that really mean? How could these dollars be diverted more into that care? And how could these dollars be diverted more into people accessing their medicine so that they can stay healthy? Like, everybody wants to, have your medicine. If you have diabetes, you want it to be under control. If you have heart disease, you want to be able to control it so that you can be here longer for your families and for other people that depend on you.
John, to bring you into this discussion, on one hand, you have manufacturers who are providing discounts, and we've discussed hospitals benefiting from those discounts. Is this ultimately a debate between big hospitals and big pharma?
Great, thanks, Stephanie. Short answer is no. There are other stakeholders, and as we were discussing earlier, employers are one of those stakeholders that there's already building research and understanding that employers can really suffer based on the growth in 340B. There can be others, and there's ongoing work to suggest that patients really aren't positively being impacted by 340B in different ways. And so there, in some cases, 340B is thought of as a victimless program, and it really could only benefit patients and hospitals. But we're seeing other impacts that are negatively going toward likely increasing premiums and things that really everyone cares about. And so we have to keep those negative consequences in mind with this program.
Thanks so much, John. This is a question for everybody. Get some dialogue going. We have some people here who are learning about 340B for the first or maybe second time. I'm curious, what is one of the most surprising things that you've learned as you've researched and dived into this topic from your various perspectives? And I'm going to go to Courtney first.
Oh, okay. One of the most surprising things I've learned actually stemmed from a New York Times article last year that talked about what was happening in a community in Richmond, in a hospital system there, where 340B dollars there were being diverted into richer neighborhoods. But the thing that surprised me the most, and if you guys have access to that article, I'm sure some of our colleagues could be able to share it. The thing that surprised me the most was to see how much a particular hospital was shutting down care. The trauma center there was shut down. The MRI machine wasn't working. People within the community were being shuttled from that community to another community. And when we talk about the patient impact, we're thinking about what does that mean for the health outcomes in that community? If you're being shuttled from your community where you have some familiarity, you know what's happening, and you're going somewhere else where you may not know the folks there. What happens? The article highlighted one gentleman who died on the way to the hospital in the richer neighborhood, just because there was a dearth of services there. So one thing that has really surprised me is that the lack of charity care that's being given, and then on the flip side of that, the lack of charity care, but then folks in these communities being stiffed with medical bills and aggressive debt collection that happens as a result.
So, Courtney, am I correct in that instance that the hospital was using their facility in that less affluent neighborhood to get into the 340B program?
They were using their anchor status, their anchor hospital in that community for the 340B status, but diverting the 340B dollars into other clinics in richer neighborhoods.
Bill, how about you?
Yeah, no, the Bon Secours story is shocking, and I encourage everybody who is interested in this program to read it because they, as Courtney said, they stripped down the main hospital, which was located in a low-income urban area in Richmond. They took out the emergency room, MRI machines, everything. They stripped it down so that they could move into wealthy suburbs, and they opened up satellite offices in wealthy suburbs where they could bring in fully insured patients and arbitrage the discounts that they were receiving. So anyway, one of the most shocking things to me about this program, it's something we didn't talk about, and to the lobbyists or legislators in the room, this should be sobering. The statute is just very sloppily written. It's terribly written. There's no requirement, for example, that the discounts have to be handed over to patients. So when an uninsured patient comes into a pharmacy, they can be charged the full price. They won't get the discount. And there's no definition of patient in the program. They didn't define which patient should be eligible for these drugs. So Jeff Bezos or Bill Gates could be a 340B patient if they're treated at a 340B facility and get deep discounts on their drugs. So that the program, the statute was just very poorly written, and it needs to be cleaned up at the federal level in particular.
Thanks so much. I know the moderator is not supposed to jump in, but for me, as I learned more about this issue, the idea that my daughter is a 340B patient, most likely, really was quite shocking to me, because the assumption was this really is a need-based program. Very early in my learning. John, why don't we jump in on what was surprising to you?
Yeah, no, a number of things. But Stephanie, I was actually, the first thing that came to mind was sort of similar to you in that my family and I have received care at the University of Colorado Hospital and Children's Hospital, Colorado. Really nice facilities that offer high quality care. And to think that we were likely 340B, patients at some point during that care when we received medicines from those entities, it's sort of shocking. It's just, as a faculty member at the university and being relatively well compensated to think that we were a part of that program, and to also think about how it's grown lately. I know CEOs of large manufacturing companies are saying that this is actually a bigger deal than the Inflation Reduction Act, which is, as probably we all know, is a program that allows the government to set prices of drugs in the Medicare program. So to think that 340B is on the radar of leaders in the industry is a part of this, and perhaps not shocking, but is an important part.
Thanks so much, John. Courtney, I mean, we've talked about 340B being billed as a safety net program. And of course, the prevailing assumption is that patients will pay less for prescription. You spoke to this. Can you talk about bottom line impact on patients' wallets and why that's so important?
Sure. One of the interesting research points that has come out when experts such as Bill and John dig more deeply into this is that the average cost per patient is more for their medicines is more than 150% higher than people with commercial insurance. And so that's important because a patient's deductibles, their co-insurance, they're based on their medicine costs, right? And so that can result also in higher cost sharing and higher out-of-pocket costs. So if you're a patient and you're faced with that, you're trying to think, if I'm going to pay my rent, am I going to get groceries? Like, you're thinking about your everyday lived experience and not really understanding that you could get your medicine at a lower cost if the rebates were passed through to them. And so I think those pocketbook issues we hear about even during election are very important to think about in these programs, because this is a program that's supposed to benefit low income, vulnerable patients, and they are labeled that because they are in medically underserved areas, right? And so that's a very huge, steep impact if you're talking about 150% markup.
John, you talked about the overall sort of health ecosystem. I know that taxpayers are a group that's really important to our audience here. What about them? Is there a data that 340B costs Colorado taxpayers any money? I mean, we hear this program really described as manufacturers delivering discounting meds to hospitals to serve communities in need. So what's the play for taxpayers here?
Yeah, the line of logic there is similar to what we already described, in that if the rebate dollars are all being moved to hospital centers, those rebate dollars aren't being enjoyed by employers or premium payers, right? And so in insurance employer-based plans, you can then see that premiums might increase due to this program. And so that's concerning. Certainly governments are employers too, so at the state and local levels. So there's ongoing work at NPC to dig into the cost to again, the state-related government employers and other state-related employers. And we suspect that we'll see similar kinds of trends there as we did at the federal level, that the 340B program is increasing those costs. And so in the end, taxpayers are paying for the government-related workers, and so you can see how that would have unintended consequences for taxpayers and others.
Great, thanks so much, John. While we're on Colorado specifically, Bill, you've shared some interesting research on contract pharmacies in particular, and I would love a little more context on why exactly there are so many contract pharmacies, some in Hawaii.
I honestly wish I could answer that question, and I've tried to study it very carefully. There's 32,000 entities now that are dispensing 340B drugs around the country. That's about half the pharmacies in the whole country. And so I went to hospital executives in Boston and I said, why do you have so many contract pharmacies? And I got a lot of different answers. In the beginning, they said, oh, well, these contract pharmacies that are far away, they're all mail order. Well, there's been some academic research that's come out that says that that's not true. More than 90% are brick and mortar pharmacies. So, and then another hospital executive said to me, well, look, pharmacies come to us and they say, okay, we're down the street from you, but we might source the drug from somewhere else in the country. So you have to sign a contract with 10 pharmacies if you sign us up. That makes a little sense, but it doesn't make sense that if you're in Atlanta, you're going to source a drug from Washington State or Hawaii. It just doesn't make sense. So the only explanation I can have for why there are so many contract pharmacies is there's so much money sloshing around in this program that every pharmacy, in particular for-profit pharmacies, have an incentive to join. I was telling that story about how when they arbitrage the discounts, a hospital could make $150,000 profit. 340B pharmacies sometimes write contracts where they can keep a percent of that spread. So let's say they could keep 10% of the 150,000 spread that the hospital is taking in. That's $15,000 pharmacy could get on one prescription. That's unheard of in the pharmacy world. Commercial health plans would never pay that kind of money. But 340B hospitals do, so that there's this rush to get into the program for-profit pharmacies and PBMs.
Courtney, on the topic of contract pharmacies, I know that there has been discussion about restrictions relative to contract pharmacies, and I'm curious about that impact, particularly on rural 340B hospitals. And so would that hurt vulnerable institutions that 340B is really intended to serve?
Absolutely. I mean, if you're thinking about a contract pharmacy in Hawaii serving Colorado and it's maybe brick and mortar, how does that help the folks here in Colorado access their medicines? You see a lot of conversation about, oh, well, let's just extend the reach of contract pharmacies. Like, let's just make more contract pharmacies. But if they're in Hawaii and they're in Florida and they're brick and mortar, that's not, necessarily helpful. And let's keep in mind, a lot of these contract pharmacies are these for-profit pharmacies, CVS's of the world. And one of the things that we see with those types of entities is that they, for whatever business reason, they may leave a community, they may leave a rural community, they may leave an urban community we're not generating enough sales, we're not doing that. And so what does that do for pharmacy access for people who live there? And the literature shows that the average person lives at least a 20-minute ride away from a pharmacy. And so, it just doesn't solve the problem to add more contract pharmacies, but also to Bill and John's point, because there's no transparency in the system, can't quite see what's happening with these contract pharmacies, where the monies are going. And so if you just, keep proliferating contract pharmacies, there's still no guarantee that when patients go to the counter, they're going to get that rebate, they're going to get that discount. And so that still has that wallet impact that I talked about to the patient right there at the ground.
Okay, so I have another question related to this topic, but I do want to flag for everyone that after this, we are getting to our Q&A from our participants. So if you look at your table, you will see some note cards and hopefully some pens or markers. If you can write down questions, and we're going to collect them and send them in for our panelists, that'd be awesome. Okay, so I want to get to solutions while we have an opportunity. And Bill, we talked about contract pharmacies. We talked about bad actors in the system, the New York Times article, Bon Secours. Can we address these issues with the system without a complete overhaul of the 340B program, specifically in the statute?
Yeah, as I said, I'm very sympathetic to hospitals that are doing the Lord's work, that have very low Medicaid reimbursement rates and that are struggling financially. So I wouldn't recommend highly going in and chopping up this program or cutting it. I think the first thing that could happen, however, is just a little transparency. Make a hospital disclose how much revenue did you take in from 340B and where did you spend it? That's all. That's all. We're not going to cut the program. We just want to know how much money you're making from the program. And what are you spending it on? Are you spending it on the uninsured? Or are you spending it on executive salaries? It'd be nice to know that.
Thank you. We're getting some questions in from the group, and we actually just addressed one, which is, are you suggesting the 340B program be scrapped? So I think it's clear we're not suggesting that.
Yeah, definitely not suggesting that. We just want it to work as it was intended to work. And I think to double down on Bill's point about transparency, let's understand how much you are giving in charity care. Let's understand how much you are sharing rebates with patients. And if you're not, then we need to rethink, how that's happening. And we need to see some better transparency around that. I will say that on Capitol Hill, there's a lot of conversation about this. Senator Cassidy has asked pharmacies where they're spending their monies. He's asked them for more information. There have been a couple of hearings. There's going to be more conversation about this, I'm sure, in the new Congress, and there's lots of movement on this in the state. And so I would also just reiterate that this is a federal program, so it requires a federal fix. To the extent that I know a lot of you in the states are hearing about it, and there is legislation popping up in different states, but it requires a federal fix, and so it requires our Congress, our Senate, our House to ask those tough questions, to make those tough calls, to say we really need this program to work the way that it was meant to work.
I just had a truly innovative question come in this. How can AI help or hurt in 340B? I think this is our researcher question here, John or Bill. Thoughts on that?
I'll leave it to John.
John?
Thanks a lot, Bill.
Yeah.
AI. Boy, I guess I haven't given that too much thought. It could be that if we had, say, more transparency laws in place, that AI could be a way to mine that transparency. So perhaps, but as we all know, it's sort of the quality of the data that goes into AI in terms of then what we get out of it. And so we first need to have the evidence to then help with changes to the program. And I would agree with the other panelists in terms of potential solutions. I think seeking some sort of federal solutions that curb the growth and that bring it back to its original intent are ways forward here.
As a PhD student in a health equity program, I would say that in terms of AI, an important thing to think about, as John alluded to, is like what kind of data inputs are going in, but also thinking about bias in the system, making sure that we are, it's not inherently being built in a biased way that generates results that, would skew wildly one way or wildly the other way.
That's important. Real quick, John, while we have you, inquiring minds want to know here in Colorado, when can we expect to have Colorado specific data related to the cost of 340 in Colorado?
Yeah. So we're working to get that out, and we're actually partnering with IQVIA again and others for that work. We want, NPC as a research organization really cares about the quality of our research, and part of that often involves peer review processes, and sometimes those are things that are outside our control. However, certain cases we do work with partners to publish things in more of the white paper space, or mechanisms that can be done more within our control and time. So we think that some of that state-related evidence will be coming out, let's just call it by Q1 of 2025. So in the coming couple of months. So stay tuned.
Yeah, sure. Can you hear her? Yes. Sorry, that was State Senator asking if you can bring this forth sooner. Jake.
Okay. Well, thank you, and we're doing our best. We've got our best researchers on it. We'll do what we can.
Okay. Budget's out in March. Okay. Here is a question. There hasn't been discussion about impact on increasing drug prices that impact patient affordability and impact the overall 340B sales. As drug prices increase, doesn't this increase 340B spend?
Doesn't it increase 340B spend?
Yes, that's the way this question is positioned.
Yeah. Well, what increasing drug prices does is it increases the spread that hospitals can pocket. I mean, that's really what it does. And, we could get into a larger discussion about how PBMs encourage manufacturers to raise list prices so that they will get a bigger rebate. But at the end of the day, I think what would happen if drug prices go up is there's a bigger spread to be pocketed by 340B institutions.
And I would just say that the literature shows that drug pricing have not increased that much. They've actually held pretty steady over the last few years. But Bill brings up an interesting point that is probably a panel all unto itself, is pharmacy benefit managers, another sort of unregulated entity within the healthcare system that for whom drug manufacturers have to provide rebates to even get our drugs on the formulary so that you all can access your medicines. And so, yeah, that's a whole other panel altogether. But, you know, the fact of the matter is that drug prices are not increasing by humongous rates. They're pretty much holding steady. And that's in large part just due to the efforts of our member companies and really thinking about being smart about research and development, and thinking about the sorts of molecules and compounds and moieties, a new word I've learned since I've been in the industry, that are being brought to bear to bring new medicines to market.
Thank you so much. I'm gonna couple two questions together. One is sort of what can patients do about this? One is who's informing the general public about 340B? What tools are we providing communities, rural, Black, Brown, et cetera, to advocate for accountability?
Sure, there is a really great coalition called the ASAP 340B Coalition that's really doing a lot to bring this conversation to the halls of Congress and to state legislators. You know, it's a pretty, as you've heard here, it's a pretty weedy subject. And so trying to elevate that to a level that patients can feel empowered to go advocate on behalf for themselves, to members of Congress, to their staffers, because we all know staffers are the conduit into members. But that ASAP 340B Coalition is one that's really raising up those patient voices to help them navigate how we talk about this, but navigate and understand the impact to them as well.
John, you talked about employers. What is similar to what can patients do? What can employers do about 340B? Do they have options? Are there other choices?
Are there other choices for employers? I don't know if I have a good response to that. At the moment, you know, these funding sources for 340B entities are not going away, and so I think that is a challenge that, you know, employers could certainly demand some of the rebates come back to employers and to patients, importantly. But short of those demands, it doesn't really solve the issue, because in the end, the growth of this program is it's diverting funds away from the original intent of the payment back to, you know, to really provide to demonstrate the value of medicines that are impacting society and patients. And so with that diversion really comes challenges, right? I think we're seeing these hospitals get hungry for more and more opportunity for growth and additional revenue. And that's a natural instinct. So I don't think we necessarily point the finger at any particular hospital or entity because of that. But it speaks to us really using medicines and the value that they provide and toward additional intents outside of the original intention of 340B. And that's the challenge here in a nutshell. And so I think to the extent that employers and really all stakeholders understand that issue better and can think about solutions as well, is a number of opportunities.
Thank you so much. PBMs have been mentioned a few times. What is their role here?
Their goal is always making money. And they make a lot of money in the 340B program. PBMs have infusion centers and other ways of dispensing medicine that they make extremely profitable. They make a lot of money in participating in the 340B program because of some of the contract things that I mentioned.
And the other thing to know about PBMs is PBMs make money in various different ways, as a pharmacy benefit manager, as an insurer, and sometimes where the provider is. It's a little wonky term called vertical integration. And so, you know, they're driving profits in 340B, they're driving and holding on to profits in the commercial market. They may or may not be your insurer, so, you know, they may be causing, you know, utilization management tools when you go to the doctor in terms of like step therapy, whether or not you have to be stepped through to a medicine that might work for you. So PBMs are another entity within the healthcare system that also are a little operating in the shadows just a little bit, but they're an important player in this as well.
Okay. I think this is generally addressed at pharmaceutical industry. You call it abuse or a mandate. Hospitals are saying you're discriminating against them and pharmacies if they are limited to a certain number. How do you respond to hospitals?
Did you say that again?
You call it abuse or a mandate. Hospitals are saying you are discriminating against them and pharmacies, presumably contract pharmacies, if they are limited to a certain number. How do you respond to hospitals?
I would say, you know, we're all very important players in this healthcare ecosystem, right? We all depend on each other in sort of this symbiotic way to make sure that patients get what they need and get access to medicines. But I just think that, you know, there's a thread of fairness that needs to be threaded through the whole, you know, a whole patient's journey when they access care at a hospital or through their provider. You know, how are they able to access their medicines? And if 340B program is supposed to help them be able to get better care at a charity care hospital, if they're supposed to be able to help them to get their medicines, then it needs to work in that way.
Yeah, I was just going to say there are many pharmacies that are doing things that are illegal under federal law. For example, if a 340B drug is given to a patient who's not being treated as a 340B facility, that's called drug diversion, and that's illegal. You can't do that. The same is true with Medicaid patients. Medicaid patients, if a Medicaid patient comes in and gets a 340B drug, the hospital cannot also apply for the Medicaid rebate, which is substantial. Because if you combine the 340B discount with a Medicaid rebate, the drug would be free. I mean, and that's Medicaid rebates. These duplicate discounts are very problematic. And some manufacturers have said to pharmacies that are engaging in these practices, we're not gonna give you drugs. And I'm fine with that because I think that if you're engaging in illegal activity, that's a reason to cut you off.
John, anything to jump in on here? We don't want to leave you out of the conversation.
No, I'm good there. Thank you.
Okay. This one is specifically for you, Bill. Is the lack of charity care by hospitals at all connected to more people being insured through the Affordable Care Act? How can charity care be more transparent?
The answer is yes, for sure. We saw charity care numbers declined as Medicaid enrollment rose. There are few people walking in the door without insurance. So that makes sense that charity care would decline as the Affordable Care Act was expanded. On the other hand, the average declines in charity care do not fit well with the amount of revenue that's being secured through the 340B program. I mean, there's still 40 million uninsured people. There's still lots of people with low income that have high deductible plans that are paying a lot out of pocket for their health care. And the 340B revenue should be diverted to helping those people. And it's not. Generally, it's not on average.
Okay, this question is specifically from Rhonda Phelps. Thank you so much. It happens that the 340B plan, it appears that the 340B plan is not working as intended to ensure health equity for the most vulnerable. Describe how to build bridges to grant greater access to communities where there are food deserts and pharmacy deserts. That's the most eloquent question we've received.
Yeah, that's a great question. How to build bridges. One of the things that we feel very strongly at PhRMA is to ask communities what they need. When we started a lot of our health equity work, we heard a lot of feedback that said, come to us and ask us what we need. Ask us what are the solutions that would be most helpful to us. And so I think that that's part of what what the ASAP coalition is trying to do. And certainly in our advocacy efforts at PhRMA is to ask the patient, what is it that you need? How is it that you're not being served? How can we connect you to patient advocacy groups to help build those bridges, to understand, how you may be able to access your medicine. If the 340B program is not working for you, let's get you connected to patient assistance programs so that you can remain adherent to your medicines while, we're winding through all the policy that's happening on the state and federal level. Because let's be honest, like, policy fixes can take a long time. People need help right now. And so how can we facilitate that from an industry perspective is something that all of our member companies have leaned into from a health equity perspective.
And our last question, I'm not familiar with this, but hopefully one of our panelists is there a connection between the Steward Health collapse and 340B abuse?
None that I know of. I mean, I think Steward was a for-profit hospital and so wasn't participating in the 340B chain. I could be wrong about that, but that's my general sense.
That's actually an important point, Bill. So 340B hospitals must be nonprofit. Is that right?
Correct.
Well, okay. With that, with our questions concluding, I would love for each of our panelists, surprise, to leave us with the 1 to 3 key takeaways you think that people should leave this session with from your perspective. And I'm happy for someone to raise their hand to go first.
I can go. Yeah, I can go ahead and jump in. It's been great to be with you all. I think one of the myths of 340B that I'd love to leave with you all is it's a federal program, and the myth is that the federal government is funding this program with dollars, and uninsured and low-income individuals are benefiting, and yet we're seeing that the federal government isn't providing financial support for this program, that it's on the backs of others, including even employers, and we're not seeing, in many cases, that patients benefit from the program.
Thank you so much, John.
I would say, think about the most vulnerable among you. Think about your neighbors, your friends, family who may be trying to access their medicines through this program. See this through that lens, but also think about the health outcomes, the health impacts, what it means when you can't access your medicines. Does that exacerbate a condition? Can someone die if they're not able to access their medicine? So just really thinking about those things that help people stay with their families longer, be able to work longer, be able to enjoy life. Really think about it and evaluate and ask people in your district or your hospital systems here, what do those health outcomes look like in those medically underserved areas, and how can we improve them?
Thank you. How about you, Bill?
Yeah, I see one of the biggest challenges in the current healthcare system is people are paying more and more out of pocket for their care. They're in high deductible plans or they're uninsured, and there's millions of people that are paying lots of money out of pocket for their care. And here we have this multi-billion-dollar program. It's one of the biggest federal drug programs that's throwing off billions and tens of billions in revenue. And a lot of that revenue is not being diverted to offset out-of-pocket costs of patients who are genuinely struggling to pay for their medication or pay for their MRI or pay for whatever. And I think it's a shame and it needs reform.
Thank you so much, Bill. So before I call Dana up to close us out, I would love if you would please raise your hand if you learned at least one thing you did not know about 340B. Have we kept our promise? Okay. If you did not raise your hand, please see me. We would like you to be a panelist. Thank you so much. We appreciate all of your very valuable time. Dana?
Before we let you guys go, I know this was a lot of information. And as I said in my opening remarks, no issue in healthcare is black and white, okay? You heard from our industry's perspective today, and we very much appreciate you spending an hour or more with us to hear that perspective. And I encourage you to talk to your colleagues and your neighbors in the room about their perspectives as well. And as Bill mentioned several times, in this program, there is wonderful work being done, and I don't want that to be lost on this room either, both in the community setting, in the pharmacy setting, and in the hospital setting. But we want that good work to be happening everywhere. And so I really appreciate the attention to transparency in this discussion, the attention to health equity, the attention to impact on employers. And I hope to continue this discussion with all of you in a robust way as we move forward. Thank you so much for your time today. And thank you so much for the continued dialogue as we dive further into this issue. Have a great rest of your week, everyone.